This afternoon, we're pleased to have three individuals from the OSU Personnel Services Office to visit with us about a couple of topics, kind of a general update on some of the benefits, and then specifically some discussion on the new prescription drug card that will go into effect this July 1. So at this time, I'd like to introduce Barbara Wells, who's the Assistant Director of Personnel Services in charge of benefits, and I'll let her introduce the rest of her staff. Barbara?
Thanks, Tom. It's always fun to come to the branch campuses. This is actually the most fun thing I do all year long, so I really enjoy coming out to be on your turf and visit with you for a while. I do have two staff members with me today. Kathy Conway is sitting at the table, and John Dalton is at the door helping with the handouts. John, by the way, is going to be the prescription card expert in our office. So he's going to be your contact person if you do run into situations where you need some help in changing dependent information or getting things going right. So we brought John because we wanted you to see him, meet him, and become acquainted, since he will be working with you. Also, I have an announcement. We brought with us today some benefit packets for each employee who is enrolled in benefits. The packets are labeled, personalized with your name. Therefore, we couldn't hand it out at the meeting today, but your personnel department will be handing these out shortly. Inside this packet is all completely new benefits information. There's a brand new medical certificate in here that has even the July 1, 1995 changes. So you'll want to bear that in mind when you're looking at it today, that some of those coverages do not go into effect until July of 95, but current up-to-date information. Also, an important publication in here is a brand new publication about OSU's retirement program. And I know although that was implemented in 1993, it's not always the easiest thing in the world to understand retirement. And I think this publication will help make it simple. It's not a thick one. It's a rather thin brochure, but it will help you to understand the retirement program. So anyway, we want you to know this is on the way, and we hope that that will be beneficial. Also, everybody should have received a little survey questionnaire evaluation form when you came in the door. We would really appreciate any feedback you could give us about this presentation, about how we might improve the next time we come to your campus. Are we providing you with the information you need? Do we need to do something differently? So we really appreciate any constructive comments that you might have to help us out. Also, we did some very quick juggling on our program. We learned that at least one communication piece went out indicating that this meeting would start at 2:30 instead of 2, and other communiques going out indicating it would start at 2. So we reduced the order to put me on first, because what I have to tell you is less important than what Kathy has to tell you. So we want to be sure that everybody gets the most important information at the last. What the order of the program is going to be, I'm going to briefly talk to you about the retirement program changes and also the dental program changes, and then I'm going to go through quick overview of the entire long-term disability program, which includes the changes. And of course, when we come to your campus, we have 2-day meetings on the Stillwater campus, so each session is an hour presentation. So you get the Reader's Digest condensed version, and we try to boil it down to what's really important for you. The health care we felt like was extremely important, so we're doing our entire health care presentation for you. The others is a very condensed version. So we can be around to answer any questions you might have after the session if we don't go into enough detail, and if you need additional information. But with that, we'll get started with the retirement, and want to just briefly remind you, the change in retirement this year has to do with Oklahoma teachers' retirement, because two things have happened. One, the contribution rate is changing, and two, the cap is lifting on Oklahoma teachers' retirement, which means that those of you who have been paying Oklahoma teachers' retirement on the $25,000 base or the $40,000 base, that will no longer be an option. You will have to pay Oklahoma teachers' retirement on total compensation. So what this means is that a lot more money is going to be shifted to Oklahoma teachers' retirement. There is no change in the contributions that the university pays on your behalf. So the university still pays the 711, which is 7% of the first $11,520 of your salary, and 11% of everything over $11,520. The big change is the shift in where the money goes. In addition, on this slide, you'll notice there's a 3% administrative fee listed at the bottom. So this does not come out of the $711 that the university pays for you, but it's an added cost that the university has to pay toward retirement on your behalf if you are a member of Oklahoma Teachers Retirement. So anyway, that is a pretty significant change. And Kathy, I'm ready for the next one. We're a team effort today, so that's our slides are away from the podium. This slide, if you're like me, it helps to see the numbers in dollars and cents on what it means about the shift in Oklahoma Teachers Retirement resources. And so we've done 3 salary examples just to give you an idea of where you might fall in, and we'll look at the $20,000 salary example. If you earned a salary of $20,000, the university would be paying in your behalf $187 a year in in life insurance premiums. In addition, the university would be paying $1,830 a year for the medical premium. And the 711 contributions for retirement would be $1,739. This means your total compensation would be $23,756. Teachers' retirement contributions would then amount to $1,425 for this particular example. So with you having a total of $1,739 available toward retirement and $1,425 going to Oklahoma Teachers Retirement, that leaves only a balance of $314 to go to TIAA credit. And if we could hop over to the $60,000 example, because here's where you're going to see some significant difference on your payroll advice and your TIAA credit statements. The 711 retirement contributions amount to $6,139. There's no change whether your salary was before July 1 or after July 1. The university's retirement contributions remain the same for you. The big change is the amount that it takes to fund Oklahoma Teachers Retirement, which is $4,547 in this example. If this person were in the low base paying on $25,000, this person would have paid only $1,500 to Oklahoma Teachers Retirement out of that $6,100 available for retirement. And what that means is much more money is going to Oklahoma Teachers Retirement, less money to TIAA credit. So you get the same retirement dollars, but there's a different distribution of where the money goes. And the reason I'm emphasizing that is so that your personnel department and our personnel department doesn't have a whole lot of telephone calls later on in the year when you get your TIAA credit statement and say, why is there no money going to TIAA credit like last year? Indeed, there will be much less money going to TIAA credit. Also, if you see your payroll advice and say, why is so much money going to Oklahoma Teachers Retirement, that is the law. So just want everybody to be aware of that. Any questions about retirement before we move on? Can everybody in the back hear okay? We have a wonderful group here. Can you hear way back in the back on the wall? Okay, good. Wonderful group. Appreciate you all showing up. That's terrific. Okay, on the dental. In the interest of time, we're not going to go through the whole dental program, but we do want to review the changes in the dental program. Fortunately, there will not be a rate increase this year, and we have had very good loss experience the last couple of years. However, the first year that we implemented the dental program, our loss experience was horrible, and that might be expected because we didn't have dental insurance before. So those of us who enrolled in the dental insurance went out and got our teeth fixed and really ran up the loss ratio quite a bit. But this year with it being good and last year with it being good, we negotiated a new accounting system with the dental company. And what this means, it's a retention accounting system, and if we continue to have good loss experience, they will be charging us only the amount of money that is necessary for their overhead and their expenses And the surplus money will remain in the plan to offset future rate increases. So if we, because of medical inflation, if our dental costs start going up, which we expect that to happen, we will have a delayed rate increase if we continue to have good loss experience, because there will be a buffer amount of money there to help delay a rate increase. So that's really a good deal for us. The next item has to do with we will no longer prepay the premiums. And those of you who pay a medical premium were aware that we made a change in February and did not charge employees a premium, nor did the university pay a premium, because we switched from prepaying premiums to paying premiums during the current month due. We will also do that on the dental program and make the transition in September. So those of you paying a dental premium will not see one in September, so don't get alarmed and think that something's gone haywire. The other change has to do with an open enrollment opportunity to have a 6-month late entrant instead of a 12-month late entrant. What the late entrant situation is, if you fail to enroll in dental insurance during the first 31 days of your employment and you decide to enroll later, normally you would have preventive care for a period of the first 12 months before all of the other coverages would be available to you. During this open enrollment period between now and May 31, Emeritus agreed to reduce that to 6 months. So anybody who enrolls before May 31 would have only the 6-month late entrance penalty instead of the 12 months. Does anybody have questions about dental? Okay, we'll move right along. One thing I failed to mention to you at the onset of the meeting, and I intended to, we expect our entire program to take a little over an hour. So if anybody does need to leave and has to get back to work, we certainly understand if you need to leave, but hope that you can stick with us. On long-term disability, as I mentioned earlier, we're going to run through a quick overview as well as the changes which will be covered in the text of the overview. Long-term disability is a salary protection program, and it's insured through TIAA. And you may recall that we made a change last year so that the employee pays all of the premium, whereas in the past, the university paid 2/3 and the employee 1/3. And of course, employees who were enrolled in LTD got an adjustment in the salary because of that change. I just want to remind you, in case it's foggy or you didn't attend the previous meetings or didn't see the literature about the reason for that, it has to do with the tax consequences. If you pay, and I pay, the entire premium, and if we become disabled, then it's a tax-free benefit to us. Whereas if your employer is paying the premium, then it's taxable. If you have to use the long-term disability insurance, then you have to pay tax on the benefits you get. So for the small amount of premium involved, the health care committee, and I certainly agree with that decision, thinks it's far better to do it this way. The Internal Revenue Service does look at the last 3 years, which means that you would have to be paying your premium for 3 years in order to be home free without having to pay taxes. So anything in this first 3 years while we are in transition, if anybody becomes disabled, you still would have a tax obligation pro rata based on how much premium you pay and how much premium the institution pays. And on long-term disability, this is a program we've had a very, very high loss ratio. In other words, our loss experience has been very bad. Despite the bad loss experience, we've not had a rate increase since 1991. We are really pleased with what we call the horse trading that we've been able to do to keep the rates stabilized. Because in looking at our experience figures, I'm actually surprised that TIAA has agreed to the small amount of tweaking in coverage that they've done to leave the rate stable. But we have been able to maintain the rates by slight coverage changes. And one of the changes this year has to do with alcohol and drug disabilities. Those in the future will be treated like mental nervous disabilities. And the situation there is that you have 24 months of coverage unless you are institutionalized. And if you are institutionalized, then you have extended coverage. So that is one change in connection with alcohol drug cases. Another one is to match retirement for active employees. And I don't know if you're aware that in connection with long-term disability, if you become disabled, you not only have your salary guaranteed and get that salary check each month or that benefit, you also have an annuity that TIAA is paying into a retirement contract so that when your long-term disability benefits end, you won't be left on the street with nothing but Social Security. You will also have an annuity from TIAA credit for retirement annuity. In the past, the long-term disability retirement annuity has been richer than what we were paying for active employees. And so this was not a difficult decision at all to change this as part of the coverage sacrifices in order to keep the rate stabilized, because it should not be greater than it is for active employees anyway. The final change has to do with no inflation adjustment. Currently, if you become disabled, your benefit would increase 3% per year, and we did give up that inflation adjustment. So now, if you became disabled, whatever amount you were entitled to at the time of disability would be locked in for the duration of your disability. The final couple of changes have to do with premium. One of them is the same as medical, life, and dental. We will no longer prepay premiums. This change will also occur in September. So those of you paying a long-term disability premium will not have one charged in September. The other change has to do simply with administrative simplification, but you might possibly see a variation on your paycheck. The way we were calculating LTD premium in the past, if we signed you up as a new employee, we have to have a little calculator by the desk, and we have to project what your salary is going to be for a year, and then divide that by 12. And we plug in a figure that is then charged every single month. So it's a lot of administrative work. What this change is, it's going to let the computer do the work. We just plug in that you've got LTD. It calculates it based on what your salary is each month. But we did not change the definition of salary. So, for example, overtime pay is not covered by long-term disability. We don't charge you a premium on it. We won't with the change either. But the only way you might see a change would be, for example, let's say you take 3 weeks off work and you only have 2 weeks annual leave. So you take a week without pay. Your LTD premium is going to be less under the new system because it's tied to your actual pay, and you didn't get a full month's pay. Whereas under the old system, you had a flat rate that we had plugged in. So this is mainly an administrative simplification and should not be alarming to anybody. Next one is just a reminder about what it takes to qualify for long-term disability. During the first 12 months, you have to be unable to perform your existing job. And after 12 months of disability, you have to be unable to perform any job that you're suited for by education and training. So, for example, if I were a full-time presenter doing presentations all the time and lost my voice, I wouldn't be able to do my existing job. Chances are I could qualify for the first 12 months, but after that, I probably would not qualify because I can probably pound away on the computer and do some other useful things. So that's basically how that operates. If you are enrolling in long-term disability and your personnel office has the forms, there is a pre-existing condition clause you need to be aware of. If you have any pre-existing conditions, you would not have coverage for the first 12 months. There's also another very good benefit in connection with long-term disability, and that's the university's leave policy. For anybody who is covered by long-term disability, the university has a 180-day leave policy. And you're not entitled to this unless you are in the long-term disability insurance program. What this means is if you become disabled, the insurance doesn't start for 6 months, which is 180 days. So while you're waiting for the insurance to start, the university is going to cover you by the disability leave. You would first use your sick leave and your annual leave, and any remaining time to make up the rest of the 6 months would be the disability leave program. So it is a very good benefit. As for the insurance itself, it guarantees 2/3 of your salary to $4,000, but any other disability benefits that you might receive would be subtracted out of that guarantee, and that could be Social Security, workers' comp, teachers' retirement, unemployment, and TIAA CREF if you chose to activate your TIAA CREF account. But we certainly would not recommend that you activate it because you are not required to do that. It would be better to let it accumulate until retirement. And another reminder about the annuity benefit in connection with long-term disability. Even if I thought that I wouldn't get any disability insurance at all, like if I thought my teacher's retirement, everything else, Social Security would guarantee me 2/3, I would personally purchase long-term disability just for the annuity benefit because the premium is so low. But if you are to become disabled, in addition to the salary guarantee, there is the annuity benefit, which is 7% of the first $960 of your monthly pay and 11% of salary above $960. And here again, this matches the 711 contributions. We've just converted it from annual to monthly basis. The duration of the time that you can continue your disability benefits depends on when you become disabled. For most of us, it would be to age 65. If you become disabled under the age of 60, then you would have disability benefits to age 65, at which time you would want to have some retirement accumulated. And the rest of it shows other ages. Here again, I would like to point out the last line, which is one of the changes. Alcohol and drug-related disabilities will have a 24-month limit unless confined. And the final transparency for my part of the presentation has to do with the cost associated with long-term disability. And we've prepared this chart so you can, if you're paid hourly or if you're paid monthly or if you know what your annual salary is, you can find yourself somewhere along the grid. But Kathy, if you would point to the $1,500 a month salary and the monthly cost for long-term disability, if you happen to earn $1,500 a month, would be $8.33 a month. You would have a guaranteed monthly benefit of $1,000 per month income. In addition, the long-term disability plan would pay $127 a month into a retirement annuity for you, so that at age 65, when the disability ended, you would have a retirement account. Does anybody have questions about long-term disability?
Yeah.
Yes.
Are these slides going to be given to us somehow?
I don't object to giving them to you, but we didn't bring copies. I'd be happy to make a set either before we leave or so we'll be happy to. Any other questions? Okay. At this time, I would like to introduce Kathy Conway. She is our benefits coordinator. She's going to run through the health insurance changes, and so I'm going to assist her and be the hands on this project.
Like Barbara said, it is our pleasure to be here with you today. I have never been to this campus before, and I think it's a lovely campus, and it was just wonderful meeting Sharon and all of her staff. I talked to them on the phone or through email, but this is the first time I've had a chance to meet them in person. Let us begin by noting three important components on the health care plan. We have a comprehensive policy, managed care, and wellness. The OSU health care plan is self-funded, which means that the money that you and OSU pay into the plan is used to pay the claims. American Fidelity administers the plan for a fee, but it is not a traditional insurance arrangement whereby the insurance company bills in a profit in the rating structure for them. Since this is a self-funded plan, employees are partners with OSU in keeping the costs down. Employees also share in the cost on claims through the comprehensive policy co-payments. The plan and you pay a percentage of UCR, which means the usual and customary rate. These are the prevailing physician rates in a given geographical area, and these are based on zip code and physician charges. The plan covers 80% of UCR co-insurance on the first $10,000 for each insured per plan year, and 50% or 80% co-insurance on mental nervous. The 80% co-payment applies if you use the employee assistance plan. There is a $250 deductible and a $500 family deductible, and we'll be explaining this change in a few moments. Just a quick review of the coverage limits might also be worthwhile. The comprehensive policy limits are $1 million lifetime per insured, $250,000 annual per insured, $35,000 lifetime limit for mental nervous, $10,000 annual limit for inpatient mental nervous, and $2,000 annual limit outpatient mental nervous. You can find all of this information on the first 2 or 3 pages of your medical certificate. The second component of our health care plan is managed care, and this includes Health International Services, and the OSU Wellness Center has become a PPO, which means Preferred Provider Organization. One of the most important things to remember about Health International is to contact before hospitalization and before outpatient surgery, and to call them when going in for emergency admission within 48 hours. If you cannot call, a family member could call, or a friend, or the hospital. And I learned from listening to Health International at the benefits fair yesterday in Stillwater that their 48 hours doesn't count weekends. So they don't work on the weekend. So if you call after 5 o'clock on a Friday and they're gone, then the 48 hours actually is working days. So that'd be 2 working days for you. Health International has a utilization review, HI Cares, tertiary care, and also Healthy Babies. The utilization review can be a second surgical opinion. They don't require this very often, only 4 or 5 a month, and only 4 or 5 a year have differing first and second opinions. And they do pay 100% for the second surgical opinion. While in the hospital, there can be a pre-admission review, a concurrent review, and a discharge planning. The HI Cares is a totally voluntary program. It identifies chronic problems, and HI works with families by analyzing data from American Fidelity on how many times an individual has been hospitalized to offer help to keep people out of the hospital. The tertiary care, HI is an expert advocate in your corner for transplants, heart or brain surgery, and joint replacements. They can locate quality medical providers and negotiate prices. They'll try to keep you from going over that $250,000 a year limit. Healthy Babies, if you call during the first trimester, and you should call your personnel office to do an intent to insure, HI will identify high-risk pregnancies and special coverages if possible. In case of high-risk pregnancies, they can authorize coverage for something that might not ordinarily be covered. And as you came in, I think every one of you picked up one of these HI brochures. The representatives from California yesterday brought these with them, and we had several extras and brought them along for you. Are there any questions so far? Yes. This is when HI determines through their... Oh, I'm sorry. The question was, for the second opinions, is that when the individual decides on their own that they want to get the second opinion, does the health care plan pay at 100% for that second opinion? That answer would be no. That's when Health International determines that a second opinion needs to be done. Okay.
What you can do, though, you can contact Health International and tell Health International that you want to have a second opinion. Chances are they would authorize it, but it does have to be authorized for them to pay it 100%.
Thank you, Barbara. Any other questions? Okay, we'll move right along. Regarding the wellness component of our health care plan, we would like to mention 3 features. There is the routine health screening. This is an area we will discuss in more detail in a moment as we continue to expand the coverage in this area. There's also the wellness screening. This is a $20 blood pressure, cholesterol check, body composition, height, weight, and health risk appraisal, which is offered through your wellness facility. If you meet the healthy lifestyle criteria, you as an employee may be eligible to receive the $55 wellness incentive in the fall. And we have Vitality magazine. Vitality is paid with insurance dollars as an educational publication to bring wellness and medical information to your home. OSU also publishes a 4-page center insert, and we communicate a lot of benefits information there. So if you don't read any of the rest of the magazine, the middle 4 pages are very important for you. Now let's quickly review the January 1995 changes. The OSU Wellness Center became a PPO, that's Preferred Provider Organization. This means you can have 100% coverage, not the 80-20 copayment, if you come to Stillwater and use the Wellness Center for medical services that would otherwise be covered. Their charges are subject to the deductible. The OSU Psychological Services and OSU Speech and Hearing Clinic services are now covered by student practitioners. There's some detail in your new medical certificate about this coverage and the credentialing requirements for the coverage. The $20 screenings are now included for insured retirees, their insured spouses, and your insured spouses. And we began paying current month of premium in February. This was good news to anyone who pays a medical premium. February's take-home pay was increased because no premiums were collected. We no longer prepay premiums. Instead, we pay during the month of coverage. Okay, we'll tackle the easiest of the July changes first. We will have a deductible change. It's $250 per person and a $500 deductible per family. The plan will no longer require 2 separate $250 deductibles per family, and this will be the benefit for an employee who has more than 2 family members. Do you have any questions about the deductible? Yes, sir.
Okay, I take it once you hit the 500, it kicks into the 80-20. At what point does it then go to 100%?
That's when you reach the $10,000 annual limit per insured. And if you're a single, if you have employee-only coverage, you pay $250 for your deductible. And those start every plan year, and the plan year is July 1 through June 30. Any other questions? Another change is in keeping with the idea of promoting wellness. That is to expand the wellness coverage to $200 for employees when they are insured for 1 year. Previously, this was $100 for employees over age 40. So you don't have to be middle-aged to receive this benefit. And this is $100 for spouses over 40 when insured for 1 year. Previously, for spouses, this was $100 when over age 40. This coverage applies to spouses of insured employees and retirees. We have also expanded the services that can be covered under the routine health screening. Currently, the plan provides the following coverages: an annual physical examination, which could be a GYN exam or a PSA exam, mammography and interpretation, lab tests, and the exercise tolerance test. But beginning July 1st, these services will also be covered by the $200 or $100 benefit. Weight management, this must be prescribed by a physician and supervised by a registered dietitian. smoking cessation must be prescribed by a physician, a vision exam by an ophthalmologist or an optometrist, and this does not pay for glasses or contacts, just for the exam, and a hearing exam, and this must be conducted by a state licensed audiologist. Any questions about the increased wellness? Oh, I see a few hands now. Yes.
Those items you just mentioned are not subject to the deductible, that's correct?
That's correct.
The $200 maximum.
Yes, for employees. For their insured spouses, it's $100. And you have to be insured for a year, which probably most of you, a lot of you are. Yes.
So if the, say, the 30th of July, I want my eyes checked, would I just take the form from the personnel to the eye doctor, and they can fill it out and send it?
If your ophthalmologist or optometrist will fill that in for you and send it in for you, that's fine. I would make sure, or you can do it yourself. I would make sure that you write on the claim form very clearly that this is your wellness, your yearly wellness $200 exam allowance, so to speak, and that way American Fidelity will know clearly what this is being applied to. So they'll pay that properly. Do you have any other questions? Yes.
Just the way you just worded that, can they spend their whole 200 on vision?
That's right. It's kind of like a shopping list. You have a certain amount of money to spend, and you can spread it out any way you want to. Yes. Was that? Okay. Any other questions about the wellness? Yes, ma'am.
You said that includes insured spouses. What about insured children?
At
Like
this
for the
time,
vision?
yeah, at this time it doesn't include children. Okay. Now we'll talk about the major change, the prescription card service. The prescription card service is through PCS Health Systems Incorporated, and they're located in Scottsdale, Arizona, and in Dallas, Texas. The service covers all insureds with American Fidelity as primary. If our insurance provides secondary coverage, that is second to Medicare or the state plan, which would be some retirees, the prescription card service will not apply. How does it work? You provide the dependent information to your personnel office, and OSU sends this dependent information to PCS. We already have the information on all of the insured employees. PCS issues 2 cards per family, and that would be 1 card if you have employee-only coverage. The card works at network pharmacies like a credit card. If the name on the prescription and the date of birth match the data in the PCS terminal, the prescription is authorized by PCS. You probably wonder how to know if your pharmacy is in the network. The easiest way is to find out by asking your pharmacist. But you may also call a PCS 1-800 number for this purpose. However, it will not be difficult to find a network pharmacy because there are 47,000 pharmacies in the USA, including all the major chains, Walmart, Albertsons, and all the others. And 92% of all the pharmacies in Oklahoma are in the network. You basically have a 20% copayment responsibility on prescription drugs. You have a minimum payment of $5 and a maximum of $25 per prescription per month. Based on the allowable cost of your prescription, your copayment would look like this. If your prescription costs below $5, you'd pay the full amount. If your prescription is $5 to $25, you pay $5. If it's $25 to $125, you pay 20% of the allowable cost. And if it's over $125, you pay $25. This is quite a benefit for many employees who have very high prescription costs each month. Barbara's told me about some employees she knows who have prescription costs of $1,000 a month for 1 prescription. Under the current plan, at the 80/20 through American Fidelity, they would be paying $200 for that prescription. Through the PCS, it would cost them $25. Are there any questions about so far? Yes. Each prescription would be counted separately, like if you're taking 2 different drugs, then you pay, each one would be figured separately. If each, he asked the question, if he went to the doctor and he gave him a prescription for 2 separate drugs, each drug costs $25, you pay $5 for each drug. That's correct, yes. Were there other questions? Yes, sir, in the back.
Does this still apply even if you reach the 100% deductible?
Okay, we're coming to that in just a moment, but there's no deductible.
Well, I mean, if you're at 100%, if you met your medical deductible and American Fidelity is paying 100%, how does that work?
This is completely carved out separately from American Fidelity. So beginning July 1st, you would be purchasing your prescriptions through PCS, either using the card or you could send in a paper claim to PCS, similar to the way you do.
It's 2 insurance companies then, sort of.
Yes, sort of. Yes, sir.
You're talking about the allowable cost. If we assume that the pharmacies that are part of this network, that they are charging the allowable cost, or is it possible that they're charging more than what you're allowed? You understand what I'm saying?
I think I have
A
a...
reasonable customary, whatever you want to call it.
Barbara, do you want to address that one?
Any pharmacist in the network will charge the allowable cost, and our particular program has negotiated a 13% discount off what the pharmacist would charge retail. So it will be less for you, even your 20% copay. If we were still with American Fidelity, chances are you would have paid 13% more for the drug, so you would have been paying 20% of a higher amount than you will be through the network. So it is a discounted price. Anybody in the network, your copay is going to be 20%, period. But you do have a minimum of $5 and a maximum of $25 per prescription per month. So
are there any other questions? Yes.
The amount that the employee must pay for the drugs, is this reimbursable under the flex benefit?
Yes, sir, that is. And if you keep your receipt, it's my understanding that the pharmacy will give you a printout of what the percent that you pay, and that you can turn that in to Fringe Benefits Design. That is flexible. Yes, ma'am.
Does this have to be just generic drugs, or does it cover all drugs? Because some of them that my husband is taking, they have no generic for.
Okay, I'm coming to that in just a moment, but to answer your question, if there's no generic drug available on the market, the plan does cover the brand. Okay, you basically have, okay, I've already done that one. Excuse me. Many of us take maintenance medications for high blood pressure, allergies, or whatever. If this is the case, you may obtain a 34-day supply the first time you use the card, with a 100-day supply thereafter. There is a $5 minimum copayment. If you order up to a 34-day supply, your maximum copayment would be $25. If you order up to a 60-day supply, your maximum copayment would be $50. And if you order a 60-day or more supply, your maximum copayment would be $75. So your minimum is $5, and depending on how large a supply you're getting, your max could be $25, $50, or $75. The prescription card should be an advantage to employees because of convenience and no need to file paper claims. However, there are some pretty significant coverage advantages too. Mental nervous drugs are covered at 80%, not the current 50%. Pre-existing conditions are covered, and prescriptions do not count toward the maximum coverage limits, which a gentleman asked a few moments ago. And prescription drugs purchased through PCS do not apply toward the deductible. So you have first dollar coverage for prescriptions. Beginning July 1st, you use your card, it does not apply toward the deductible. This plan encourages the use of generic drugs for some pretty obvious reasons. Generic costs usually equal about 50% of the brand cost, and the plan covers the negotiated price of generic drugs. We have the 13% discount. If you request a name brand, you pay the difference. However, if your physician requires the brand, and he needs to write this on the prescription, the plan pays. Also, like I said before, if no generic drug exists at all, the plan pays. If you're like me, you're concerned about quality first and cost second, especially when it comes to your health. I've learned some reassuring things about generic drugs while working on the implementation plan for this program. The bioequivalent generic is FDA approved. It enters the bloodstream at the appropriate rate, has the same active ingredients as the name brands, is dispensed in the same dosage, is taken the same way, and is packaged in the same unit strength. 40% of brand drugs do have a bioequivalent generic. And we were just wondering if any of you can share in the audience any knowledge about generic drugs, any experiences you've had using them? Yes, ma'am.
I've had bad experience with generic drugs. My system is sensitive to generic drugs, but I can't take them. So they don't do right by me.
Well, in that case, perhaps your doctor, if he's aware of that, he might request that you, on the prescription, that you have a brand name. Speaking personally, one of the most important things that PCS may do for us is their utilization review service. With the latest medical information loaded in their database about various drugs and possible effects and interactions with other drugs, they can send electronic messages to the pharmacist. If there's a potential for a drug-related illness, for instance, an example might be a warning that would alert the pharmacist that a drug should not be taken by anyone who is pregnant. In this case, the pharmacist would ask if the patient is pregnant. Also, after you've used your card a few times, your history will be on the screen. And it will tell when your prescription was last filled. If you attempt to fill a prescription too early, your request to do so may be denied by the pharmacist. Generally, you must use about 75% of the prescription before obtaining a refill. Also, other medications that you are taking currently would appear on the screen. And any possible harmful reactions there would be an alert. If your pharmacist gets a message about possible harmful interactions of several medications that you are taking, he or she should then contact your physician for confirmation regarding dispensing the prescription. And also, PCS sends information to physicians. It's my understanding that these are bulletins and improvements in drugs. Doctors are very busy people, and a lot of times they do not have the time to study the latest drugs on the market. You're probably wondering what the plan is and how to get these cards into your hands. We requested dependent data back in March, and like I said, we have the data on all of our insured employees already. It's vital, if you have not returned that information to your personnel department yet, that you do so as soon as possible. If you've lost your letter, you can provide the information on one of our new benefit election forms that we just gave to Sharon this afternoon. It's It's also vital that you keep the data current on your dependents. We'll transmit the data to PCS, and the cards are expected in late June. Along with the cards will be a confirmation report. These reports will list the dependents covered and the birth dates and social security numbers in our system. Please check quickly and let us know if we need to make any corrections. We send corrections to all the data to to PCS once a month, and we think right at this time it'll be at the end of the month. So if there's a change to be made, and we know about it in the end of July, it may be mid-August before it's actually in the PCS system, and you can use that card for that dependent. We hope this does not happen to you, but if the card does not work because a dependent is not recognized, you should contact your employer, your personnel office. If your dependent information is not correct in the database, the PCS system cannot authorize your claim. The card does not work if you refill too soon. If the pharmacist gets this message, you can refill later, or you may contact your employer. If you're going on vacation, or for some reason you're going to be away and you want to refill sooner, then you need to call either the personnel office or John Dalton. I'll ask John to stand up in just a moment, and tell them why you need to refill early. And if there's a legitimate reason to do so, then we'll authorize PCS to let you refill early. John, would you like to stand up? John is going to be our PCS expert. And he's learning all he can at the time, and he'll be the man to get in touch with. He's going to be sending the information to PCS. Now, if the card doesn't work, you need to pay full cost of the prescription and file a paper claim to PCS. In your benefits packets that you're getting, there's a yellow card, and on it are all the phone numbers for all the insurance and retirement providers that we have. And there is also a speed dial number for you to use if you're at work. And PCS is listed, and the 1-800 number is on that card. And this 1-800 number will be available starting June 1st. So if you need to call them, this is where you get the number. Also, when you receive your card, on the back, we're planning on putting the 1-800 number on the back of that card. If you call the 1-800 number, they call this BENI services or beneficiary services. There's several things you can do by calling the 1-800 number. You can get instructions for using the benefit. You can receive information regarding items covered or not covered by the plan. You can receive co-payment information, your eligibility status, card shipment dates, status of claims, both recap, that's prior claims and direct. The PCS prescription drug claim forms, if you need one or two, you can call them and ask for them to send you some. You can learn the locations of participating PCS pharmacies, and you can also reorder additional cards or a lost card. Are there any questions about the prescription card service? Yes, sir.
If you attempt to use the card at a pharmacy that is not a member of the network, then I presume there's no, you can't file a paper claim to expect to get reimbursed. Is that true?
You can file a paper claim and get reimbursed at the 80/20 copay rate, but then you have to pay the amount over and above that. Over and above the allowable cost. Any other questions? Yes, sir.
Dr. Parkinson's, and there's no cure. And I have about 3 prescriptions. Put them together, they're about 300 a month. So they're not expecting a cure. That's the claim is just there every month, right?
Yes, sir. If you order your medication at the if you get your medication at the pharmacy, you can use your prescription card for that.
They give you the exact amount, like you take it 3 a day, you get 90 tablets in 30 days. They're very specific about not having any medication left over when you're through taking whatever series you're on. And they vary.
Yes, sir. Yes. Did you have a question? Oh, he just tilted his glasses. It's a good thing you're not at an auction. You may have just bought something. Yes.
Cover the difference in getting your medications at the doctor's office as opposed to pharmacy?
Okay, if your pharmacist, if your doctor's office has a pharmacy, you cannot use a PCS card. You can send in a paper claim to PCS. But if you're purchasing your drugs at the pharmacy that's not located in your doctor's office, then you can use the card.